Yeah, thank you many thanks, Kyra, for this extensive introduction. So I will share my screen. Yeah. So then I don't really need to introduce anymore myself. I'm Márta Radó, and yes, I worked with Károly at the Hungarian Academy of Sciences, and then we separated for a while. I went to the Netherlands and we went to Sweden, and there I um, investigated the effects of tobacco control policies on child health. And I will talk a little bit about this. I think this could be interesting in terms of methodology. And then I will talk a little bit about how these two projects led me to undertake this postdoctoral fellowship at Lincoln University. So I will first talk a little bit about my work at the Hungarian Academy of Sciences with Károly and many others. So here I don't know whether, yeah, I will do this. So you may know some of these people like Károly and Dori, and she was a master's student with us. And we worked on a paper which investigated whether there is acting by using social networks in the Hungarian social network dataset. So what the acting by theory is that some says that ethnic inequalities are deriving from partly from the fact that minority students start to exclude those other minority students who start to achieve academic success because this is considered as characteristics of the majority students. So if this is true, then this could lead to inequalities. So that's a very interesting question to investigate. And obviously, this also has social network elements. So, should I do this? Yeah. So this is just an illustration from one of the classes. And we used two methods. So we published a paper with Lila, which just used a fixed effect method and looked at the number of friends. And then we undertook a Siena model, which could investigate the co-evolution of network formation and behavior characteristics. And this is the main part of in the selection part, we use these parameters. So the part which explains how friendship changes over time. And we looked this parameter below, which is the interaction between the ethnicity of the ego and the ethnicity of the alter and the grade of the alter. And of course, the main effect for these. And so this is for the Siena model. And basically, what we found is that there is no acting bite among Hungarian Romas. So this is the good news. Yeah, but other processes, of course, is to ethnic inequalities in Hungary, but this is not the acting bite. And the second project which I did with Károly was an agent-based model, which looked at intervention, social network-based intervention. And the idea is that we know that traditional desegregation policies have both positive changes, like busing in the US, that was very successful, but still, but we can see that the schools are still largely segregated, and mainly due to that within the schools, the social networks, so for example, friendship networks are segregated. And the problem with that is that it's really, really hard to intervene to a friendship network. So I can actually tell you that you should be friends with Károly. This is not how it works. But what a teacher could do is that they intervene in the sitting arrangement. So if I want you to become friends or start to interact with Károly, I could make you to sit next to Károly. Obviously, this was before the pandemic, so you could physically sit next to each other, and then you became friends, and then you start to influence each other. So this is a possible intervention for in schools. And we looked at different consequences of different sitting arrangements. And in the right side here, you can see some of the interventions, scenarios, what we looked at. Here in the figure, the yellow figures are majority students and the blue figures are minority students, and they are ordered based on their grades. So, for example, the first one is the homophilous selection, where people with similar grades, so closer to each other, tend to sit next to each other and the same color. So majority with majority or minority with minority tends to sit with each other. This is what would happen if you let people to sit in a way they want to sit. And then we looked at other different scenarios, like the opposite, when you try to make them to sit as different people from each other as possible, or you want to sort them based on their grades and sit them accordingly. So the best sits with the best, and the worst sits with the worst, and the opposite, best sits with the worst. And then there's also we observe what happens if you sit them randomly. And what we found is that basically that we looked at different policy outcomes like talent management or inequalities or prejudice formation, and we found that there is no one sitting scenario which could be good for all the policies. So, for example, matching the best student with the worst is good for inequalities, but not that good for talent management. And homophily that leads to this is what would happen if you let them choose their peers. This leads to polarization, segregation, but not that strong one, because there is always some so-called crisscrossing agents who share demographic attributes with several groups. So, for example, in this case, minority students who study well is a crisscrossing agent because he could interact well with other minority students and with majority students who study well. So they are very important, and these actors helps to that in case of homophily it doesn't lead to strong segregation. And we looked at what happens if there is prejudice. So the majority students don't want to sit with the minority students, even if they have similar grades. But if there is acting right, so the minority students exclude the other minority peers who study well. And we found that this can actually block the crisscrossing agents, so those who share different characteristics with different demographic groups. And this can lead to a very strong segregation. So this was my work with at the Hungarian Academy of Sciences, and then I went to the Netherlands and the University Medical Center of Rotterdam. And here I investigated the effects of tobacco control policies on child health. So why is this topic is interesting? Well, this might not be very surprising to you, but smoking is really, really bad for your health. So this is the leading preventable cause of premature mortality worldwide. But what is even worse is that it's not only the smokers who get sick from this, but also children who has really, really low level of control over their own exposure. And every year they were estimated that 166,000 child dies due to secondhand smoking, and this doesn't even include third-hand smoking and other things. So it's clear that they have low control over this, so they need to be protected by policies. And we know that tobacco control policies could be good for this. And there is growing evidence that it's actually working really well to protect children. But still, around the world, 78% of the world population is not protected by a comprehensive smoke-free policy. Comprehensive smoke-free policy means that it's you cannot smoke in enclosed public places, such as schools or hospitals. Yeah, and so it's still really a large number of large share of the population is not protected. And even worse is that 86% of the world population lives in a country without a sufficiently high tax. Sufficiently high tax is defined as that the total tax is larger than 75%, which is recommended by the World Health Organization. So this means that there is still room to expand these policies. But the problem with this is that these policies are really lagging behind in low and middle income countries. And these are the countries from where before there was no evidence. And we cannot really generalize the findings from high income countries to low income countries, lower middle income countries, because there are other factors which are different. For example, other type of environmental pollutions are higher in lower middle income countries. Also, the tobacco industry interference is higher. So it's not clear whether these policies are really successful in these countries. The other factor which we looked at is that whether we talked about a comprehensive smoke-free policies which covers enclosed public places, but there are some ideas and some policies people who wants to include also outdoor places or private places to be covered by smoke-free policies. So we looked at what's the impact of expanding smoke-free policies to outdoor or private places on child health. Yeah, so there is the first study, which is under review now. And this looks at the impact of smoke-free policies in middle-income countries. And I think why it could be interesting is that it uses a relatively new method, the so-called synthetic control method. And the idea of this method is that when you try to investigate the impact of a policy, then you need to look at what would have happened if you don't introduce this policy. Without this policy. So, for example, we know that Thailand introduced a policy, and ideally, what you would do to get to know what would have happened in Thailand without a policy is that you look at Thailand with the legislation and Thailand without the legislation. But this is not really feasible because Thailand at one point of time either have a policy or not. So the second best solution is a randomized control trial. Where you randomly select countries who introduce legislation and others don't. And this could be also a gold standard. The problem with this is that you cannot really do this either because you cannot tell to a country that you should introduce a policy or not. So this is also not feasible. So the other thing what we often do is that we assume that Thailand with the legislation, before the pre-legislation trends would continue without the legislation. This is called the interrupted time series design. So we assume that everything would have been the same, basically. The problem is that there is often not the same. So might be some flu or other things which can make the pre-legislation trends to not continue actually. So what could happen is that you look for another country and you compare Thailand with another country which hasn't introduced a smoke-free policy. And the problem with this is there is not there isn't any other country which is like Thailand. Uh, so there is Bangladesh, China, Bhutan, and Malaysia, which is without a policy, without a smoke-free policy, but they are really different than Thailand. So what we could do, and what the synthetic control does, is that you actually create a synthetic control country, which is the combination of these control countries. So it's like 20% Bangladesh, 30% China, 10% Bhutan, and 40% Malaysia. So you create a synthetic Thailand, basically, and you compare the synthetic Thailand to real Thailand. So this Scrabble example, it can be said this way also, using this formula, which means that the synthetic control country is the weighted combination of the control countries. And the weights are made in a way that the pre-legislation difference between the synthetic control country and the Thailand is as small as possible. And after reducing the pre-legislation differences, you look at the post-legislation difference, and that's going to be the treatment effect. So this is what we use for multiple countries, and then we had 34 middle-income countries which introduced the smoke-free legislation up until 2018, and for 22 of them, we could construct a synthetic control country. And what we found is that comprehensive smoke-free legislation was followed by a significant decrease both in neonatal and infant mortality. And we estimated that over 3 years, 24,000 infant deaths, including 22,000 neonatal deaths, were averted in 34 countries. And we also found that if all the countries, all the 74 control countries introduced this policy, then an additional 104,000 infant deaths could have been averted, which is a lot, just in 3 years. So this was a smoke-free policy, and then we did a similar thing with raising taxes, and this will come out on Monday in PLOS Global Public Health Journal, so you can read it also. And the difference here is that we don't have a binary treatment variable, but we have a continuous treatment variable, namely the taxes, and we use for this fixed effect panel regression. We found that it's increasing the taxes 10%, also significantly lower the neonatal and infant mortality rates. And we looked at the differences between the different type of taxes, so specific tax or ad valorem, and we didn't find any major difference between them. And what's really important is that we found that if all countries reach the 75% total tax, which was recommended by the WHO, then an estimated 233,000 infant deaths could have been averted annually. So that's an even larger number. And as a sensitivity analysis, we also looked at that increasing the tax also was associated with the lower cigarette consumption. So probably this funding is really causal what we found. Okay, and then I talked so far about the effect of smoke-free legislation or tobacco control policies on infant and neonatal death. But we know that these policies have effect on different outcomes. So, for example, they decrease stillbirth and preterm birth and asthma and other respiratory tract infections. And these are all associated factors. So we created a micro simulation, which could be used to estimate the overall impact of health benefits, looking at integrating these various outcomes. And this simulation is also very useful because it could be extended to estimate global benefits or estimate the impacts of inequalities, or yeah, it could be extended in several ways. And there has been already before simulations to estimate tobacco control policies effect, but only on smoking prevalence or adult health, and all the effort which looked at child health was quite limited. So we developed this simulation using English data. We used English data because they have very good data. And basically we followed a synthetic population from fetal life into childhood. And here you can see that what this model does. Basically, the child can die dead, born dead. This is called stillbirth, or born alive before the 37 weeks. Then it's called preterm birth, or they can born term. And based on whether they are preterm babies or term babies, they have different risks for neonatal death, so dying in the first 28 days. And those who survive this perinatal part enters the pediatric part, where they have different risk factors to get admitted to a hospital with asthma or some respiratory tract infections. And they have different risk scores, so based on their preterm status, because whether they were preterm or term babies. Yeah, we estimated the overall, the total effect, the total number of deaths and hospitalizations using this simulation. And the fourth paper, so this was published in the Lancet Public Health. It's not really the Lancet, but also not that bad. So I haven't published in Lancet, just in Lancet Public Health. This is a systematic review which looked at the impact of smoke-free policies, which covers outdoor or private places, on children tobacco smoke exposure or respiratory health. And yeah, so I think this is a very good method, which is really often used in public health or medicine, but it's not really used in sociology, and I find that it's a shame. So I, for example, know that I should have done this with my PhD dissertation, and I think it's a great idea to start a dissertation doing a systematic review, and maybe we could even do a systematic review looking at different parameters for a Siena model or something like this, which I think could be useful for Bayesian models where you need to have some assumptions. But yeah, so systematic review, this was a systematic review, but a systematic review means is that you have search mechanism, and you look all the articles in the internet, like you search Google Scholars and PubMed based on a pre-specified search. And then you look at the titles, whether they fit, and then the abstract, and then the full text. And we did this, and we identified 11 studies, which was good for us, which estimated the impact of smoke-free policies covering outdoor or private places on child health or child tobacco smoke exposure. And 7 of them were very robust study. And 5 of them covered a smoke-free car policy, 1 covered a smoke-free school policy, and 1 covered a comprehensive policy covering multiple areas. And out of the smoke-free car policies, we had 10 estimations which measured the same outcome. So we could pull them together in a meta-analysis. And here you can see the meta-analysis. There are the different estimates, and yeah, we pulled them together and we estimated the overall impact, which is 0.69 relative risk reduction. And in tobacco smoke exposure, so if you introduce this policy, then that's how much you will reduce tobacco smoke exposure. And this we estimated to translate into a 0.2 to 2.4% decrease in asthma diagnosis, which doesn't sound a large number, but given the huge burden of asthma globally, this is a very significant result also. And yeah, we find that there is enough strong evidence already to say that smoke-free policies are useful to protect child health, and the other policies covering outdoor places, we still need more evidence about this. Yeah, so these were some of my studies from Erasmus Medical Center, and yeah, this two branch led me to write a grant proposal, and which luckily got accepted. And this combines the two previous research, right? And basically the idea is that we know that, or I just talked about that how these population level tobacco control policies are really useful to reduce smoking prevalence or improve child health, but we don't know yet, or there is some evidence, but people are very hesitant to publish this. We can talk about why, that these population level tobacco control policies don't seem to have a very, well, they have a limited impact on smoking inequalities, and they have a limited impact among lower social and economical status groups. And this means that there need to be other type of interventions, so not these population level big interventions, but something else. And I was thinking that the network-based intervention could be good for this. And the thing is that they don't really exist. There is one big study which used a network-based intervention, and it showed a positive impact on smoking prevalence, but not on smoking inequalities. So I wanted to look at how network-based intervention can be used to reduce smoking inequalities, and it makes sense to look at in adolescence, because this is the time when people start to pick up smoking, and yeah, most of them continues to smoke to adulthood. And I have 3 work packages, which I will try to answer. The first work package is that it's basically the acting right theory translated to smoking. And what I ask is whether there is a social, economic, or minority group differs between smoke promoting norms. So is it true also for smoking that minority students starts to exclude minority peers who don't smoke? Because if it does, then this is another level of what contributes to smoking inequalities. The second work package is about that which individuals we should target. So all the Siena models previously looked at friendship formation, but network-based interventions are also interested in other type of social networks, for example, role models. And the Hungarian dataset, research dataset, has questions about this. So I will look at other type of networks. And the last one is an agent-based model, which is looking at the consequences of different intervention scenarios on smoking prevalence and inequalities. And this has been done for smoking prevalence, but this will include also smoking inequalities. And I will look how, to this policy outcome. So basically, this is it.
Thank you very much, Márta. It was a very nice overview and of your work. So it was I think very nice to hear this, and that's very good to know about the topics that you are interested in before you join the IS. So people can come to you immediately with the questions, and also it's probably also facilitating the discussions. And also probably will lead to new projects. But before that, there is some time to ask questions. So if anyone in the audience would like to start, then of course there's a lot of things covered here. So probably I was really so then I start, because I was really fascinated by this idea of synthetic countries to use as a method because it's and then I started to think about this also in the school context where we are dealing with networks, and usually what we do is just we take the observed network and we use maybe permutation and compare the observed network with what are the possible networks given the characteristics. But the synthetic country idea is a bit different, and could potentially be used also for comparing interventions that are taking place in certain networks and not in others. It just came to my mind as a potential new method for this. But I don't know if you, because I don't know this literature at all. So maybe you can tell a bit more about this this idea and where it has been used and how is it used usually.
So this method is used for everywhere where the unit of analysis is an aggregated unit, like country, municipality, could be a school also. It was initially created for when there is one single country or one single unit who introduced a policy, and but now it's extended to multiple countries. So this is also what we did in our paper. And you can imagine everything what you would do with the regression. The idea is that it's similar to the matching literature, if you know the matching literature, that if you compare a unit with another unit using regression, and the control and the intervention units are really different, then if they are different, even if you use regression methods, you will introduce bias called extrapolation bias. I haven't bring some pictures of this, but this is basically to avoid that you extrapolate from comparing units which are not really alike. Yeah, you could completely compare schools and match them based on different characteristics, even social networks or something similar. I think it's possible. So for example, for the countries we looked at, the matching variables were obviously the lagged value of the outcomes, so infant mortality, but also we looked at the GDP and things like this. But I think for schools you could match them based on centrality measures or something like this.